We're talking about menopause today. This is something that maybe many of you have already gone through or experienced or are going through, but we're going to talk about menopause. We're going to talk about some of the general things, the timeline for it, and then some of the symptoms and what we can do to help relieve them and just things to be aware about. Menopause is when your monthly periods naturally stop. It's officially after 12 months of being without a period and without spotting. That's really considered when the doctor will say that you've gone through menopause. This happens because the ovaries stop releasing eggs. They stop making the hormones that put you through the menstrual cycle, which are estrogen and progesterone. This can happen earlier or later, but the typical ages are 45 to 55 years old. And the average age of people experiencing menopause is 51. But the transition, it often takes years, and symptoms can start even like 4 years prior to your actual last period. The big stages of menopause, we're not going to go through the whole menstrual cycle, and a menarche is what it's called when you start having your period as a teenager or younger. But prior to perimenopause, you're kind of having regular periods for the most part. And then perimenopause happens sometimes as early 40s. This can happen 2 to 8 years even before menopause actually happens. And during perimenopause, you can still get pregnant. This isn't like you've officially gone through menopause, but this is when you may start having some symptoms from some hormonal changes and from estrogen and progesterone decreasing, your ovaries decreasing production of those hormones. So you can see some hormonal changes. You might see your periods going a little bit irregular. The symptom that's the most common is hot flashes throughout perimenopause and menopause. That's like the most common symptom that people may start seeing, and hot flashes often start way earlier than seeing any changes in your period. So that's like perimenopause. This is before menopause. And then menopause is really that point in time that's like 12 months, a whole full year without having a period. And then postmenopause is after that period. You still may have some symptoms from just having lower estrogen and progesterone in your system. The biggest thing to be aware of is increased risk for osteoporosis as well as heart disease. We'll talk about osteoporosis a little bit too. So perimenopause, the average age is actually 47. I didn't mean to scare people of having it like in your 40s, but sometimes people have it as early as that, like starting to see just some symptoms start. So hormone levels are starting to change at that time. Periods may be more or less often than usual. You do start seeing shorter periods than before. They may not be as heavy and may not be as long. You may see periods more frequently though, like instead of at once a month, you may have these like shorter periods like every 2 weeks or something as you get closer to menopause. Sometimes you may even have skipped periods or lengthier times in between periods. So the symptoms that you start seeing in menopause, and you may start seeing perimenopause like right before menopause, are the irregular periods. Because your estrogen and progesterone are starting to decrease, those hormones affect a lot of different things in your bodies, not just your menstrual cycle. As you might know also just from having other symptoms during your menstrual cycle, it affects your temperature regulation and your breast tissue as well. It is also impactful of your connective tissue, which is like in your hair and your skin. So you may see vaginal dryness as another common symptom along with hot flashes. You may also notice tender breasts. You may notice some thinning hair or dry skin. A lot of people also complain about memory problems as well as mood changes. These are also intertwined with the effect on sleep. So a big impact of estrogen and progesterone is sleep regulation as well. So it can really affect your sleep as well. And then having hot flashes at night cause night sweats. And then it can also cause headaches, and it also affects your metabolism. So just how you process food, like at a chemical level in your body, that also can affect weight gain and slow your metabolism. And then the chills as well usually come with the hot flashes from that temperature dysregulation. For hot flashes, this can start, as I said, years before you actually see your periods change, or even years before you actually officially have your last period. And this can happen in many forms. What a lot of people have said is that it can start as like a sudden feeling of heat in the upper chest and face, and then spreads throughout the body. And it typically lasts 2 to 4 minutes. You sometimes sweat and then feel the chills and shiver as a hot flash. So as your temperature starts getting back to normal, it can feel like your body is getting forced into being at a lower temperature. So it starts reacting and feeling chills. You can sometimes feel anxiety or heart palpitations. This can occur once or twice a day, or it can even be like as often as once every hour. Night sweats are basically just the same thing as hot flashes, the same thing kind of happening in your body, but happening at night. And then if you had a hysterectomy, you can still actually go through a lot of symptoms of menopause. It can be harder to tell when you're going through symptoms because you may not be having periods after hysterectomy. If they didn't remove the ovaries, for a lot of common hysterectomies done, they don't remove the ovaries. So you'll still experience hot flashes and some of these other symptoms of tiredness, of memory problems, of sleep effects. You may still experience that, but it'll be harder to tell that you're going through menopause. You may not be having periods, so you may not be seeing that change, which is usually the main way that people are starting to notice when they are going through menopause. So that's something to be aware of if you have had your uterus taken out. Hysterectomy is when the uterus is taken out. Sometimes it's just the uterus and the cervix. The cervix sometimes is taken out with the uterus. Sometimes it's kind of left there. The cervix is that opening and closing tissue that connects the vagina and the uterus. The fallopian tube connects the uterus and the ovary, and there's the ovary. Typically with periods, it's caused by hormones, the estrogen and progesterone that's produced in the ovary, and that causes the release of an egg from the ovary, and it goes up through the fallopian tube. If there is sperm that is gonna inseminate, then it'll fertilize that and implant into the uterus. If not, then the uterus and the ovaries sense that there's no sperm. So it'll start building up this lining that'll be to give nutrients and provide and help implant that for pregnancy. But if there isn't, then it'll start to release all of that tissue that was built up during that month and start shedding. So that's when the period happens. That's just an abbreviation of the menstrual cycle. So a hysterectomy that many women get will take out this entire uterus, but will leave the ovary and often part of the fallopian tubes as well. But sometimes they do take out the whole uterus as well as the ovaries and the fallopian tube. And that is called a OO hysterectomy. That takes out all of it. And if you have your ovaries removed as well, you shouldn't really be experiencing as many symptoms of menopause because the estrogen and progesterone are produced by the ovary themselves. So when that's taken out, you actually go through a menopause and go through a lot of those symptoms after that surgery because you're kind of going through the ovaries not being there. So it's like a similar thing that time that you get the surgery. That is also called surgical menopause when that happens. There's something going on in your ovaries. You may have your ovaries taken out and the uterus stays. So the ovaries are taken out, then you will also go through a surgical menopause as well. When do you see a doctor if you're going through menopause? It's not like fully necessary to see a doctor as you're going through menopause unless you're feeling uncomfortable with the symptoms. Sometimes symptoms like the mild hot flashes or feeling vaginal dryness, I would suggest talking about it with your doctor because it can be uncomfortable and you may just want to know what you can do about it. You can also do things yourself too if you feel like there's no other reasons you need to be seeing the doctor. We'll talk about some of the things you can get over the counter. But if you are feeling like the symptoms are really debilitating, if you're feeling hot flashes that are super uncomfortable, then you may likely need some hormone therapy. And the other reasons to see your doctor, apart from the symptoms and trying to address those with them, if your periods are happening more often than every 3 weeks. So if you're having it really frequently, and if they're like real periods, feeling like full periods, and you're having them more frequently than every 3 weeks, then that might be a little concerning. And that might be something initially you want to be monitoring, and it may actually just start spreading out. But you want your doctor to be aware of that. You may also want to just get blood tests to make sure you're not losing too much blood and needing kind of iron replacement or anything like that as you're approaching menopause. If you're having much more heavy bleeding, then that's a bit concerning. And then if you're having a bleeding and spotting between periods, so you may notice as you get closer to menopause, you may have spotting. That's pretty normal. Menopause should usually happen that your periods may go a little back and forth, but they should be mostly starting to decrease and starting to get lighter. So if they're starting to get heavier, if you're starting to spot a lot more in between periods, that may be something to talk about with your doctor and get evaluated for how your estrogen and progesterone levels are evolving during your menopause. If you've been through menopause, you went 12 months without a period, and then you start bleeding again, even if it's spotting, you do want to get checked immediately because you shouldn't really be spotting. You shouldn't be having any of that. If there's trauma that you already know, like you've gotten a cut or from coitus or something that's from that and it like goes down in a day, then that's fine. But if you're actually seeing real spotting, you're not sure why it's happening or where it's coming from, you should definitely get evaluated because if you do have a uterus and you do start spotting, that could be concerning for cancers or other things that are happening in your uterus. So it's not to be scared about that. There's other reasons that you could be spotting, but it's all reason to be getting checked by your doctor if you've gone a whole year without a period. So testing, typically it's not routinely done as you're going through menopause. It's not really helpful. You could do testing if you're having these weird symptoms or weird patterns of bleeding that aren't really like following kind of that like trajectory of decreasing lighter periods, and you're like concerned on whether you're even going through menopause. You could talk to your doctor about that, and they may or may not feel like testing is good after they get a thorough understanding of what your menopause symptoms are, unless you're experiencing these symptoms of heavy bleeding or you've gone through menopause and you start bleeding again. Testing doesn't really tell us too much. So can you still get pregnant? If you were having a period, even if it's inconsistent, even if it's happening like every other month and decreasing, you can still get pregnant during that premenopause period or perimenopause period. If you did not have a period for 12 months, you've likely gone through menopause and you cannot get pregnant after that. It's very rare, but sometimes people do start menstruating again after menopause. It's super rare, but if that's the case, then even after going through menopause, you could get pregnant, but that's really rare. So really after 12 months of not having a period, unless you start bleeding again or showing signs from having a period, then you're likely have gone through menopause and you cannot get pregnant. After menopause, we're not suggesting to do too much birth control stuff either. During that menopause time when you are still having periods and you can technically get pregnant, that is when you may want to think about still doing some sort of birth control or like having some barrier protection with condoms, because it's still possible to get pregnant during that time. But after that whole 12 months of not having a period, you don't really need protection, with that caveat that some people very rarely will start having periods again after menopause or spotting after like a whole 12 months, which at that time they could get pregnant after menopause, but very rare.
I'm just thinking about birth control. If you're somebody who takes birth control or has something like an IUD, how would you know that you're in perimenopause if you're somebody who is taking birth control to the point where you might have irregular periods or not get a period anyway?
So you may not be as aware that you are going through perimenopause if you have an IUD or are on birth control that affects your periods. So that would be something of being aware of your body and some of the symptoms that might come with perimenopause. Perimenopause, your body may be adjusting and maybe you don't have symptoms and maybe getting ready for menopause, and that's fine. There's not really anything to do as your body is doing that, whether you have birth control, whether you have your uterus in or not. So it's not something that's like diagnosis for leading up to menopause. It is just something to be aware of, that you may start experiencing hot flashes and night sweats and vaginal dryness and all of that. So just being aware of your body and whether it's going through those changes. And if you are starting to notice those symptoms, to not gaslight yourself and be like, oh, maybe I did this. We'll talk about like some of the treatments you could just do on your own that are very harmless. Just being aware of your body and the fact that as you get over the age of 42, you may start noticing some of your hormones change a little bit and what you can try to do about that, and just being aware of your body changing. When you have a hysterectomy, when you're on birth control and IUD, you really don't have your periods telling you that you start to go through menopause.
Yeah.
So just being aware of the other impacts that menopause has on your body. But as you're going through menopause, all of those mood changes are really affected by this dance that estrogen and progesterone do in our body. You may notice more consistency of being like, oh, right before my period, I start feeling depressed or irritable. It's not going to be as consistent as that for the most part, but you may start noticing generally, even for weeks, feeling like a little bit lower or feeling like more irritable. It may look similar, it may look very different. And oftentimes it does look a little bit different just because those fluctuations are a little bit different, but they're often similar symptoms. So similar if you felt like your mind has kind of been affected by the estrogen and progesterone fluctuations or changes before or during your period, and you notice those symptoms that you get during your period, then you'll likely get those again, but they may be at a longer duration or even maybe more severe or less severe, if that makes sense. Mood is obviously very like multifactorial, so it's not always just purely from your hormone changes, but oftentimes mood swings, especially during periods, are related to your body's estrogen and progesterone. Women have often historically been kind of gaslit about like how their moods change during this, when it's really like a physiological thing that's happening in your body that's affecting your brain chemistry. So it does affect your mood. So that's all within menopause, perimenopause. Just be aware of those moods, and especially if they're kind of going back and forth, and thinking about even keeping a diary of whether that is coinciding with your period at all, and even talking to your doctor about what you can do about it. Antidepressants and medication can help stabilize the mood even during periods, but even if you don't want to do that, there's obviously all these alternative ways, and especially therapy. You can regulate your mood with different practices, and the deep breathing that really relaxes your sympathetic sympathetic nervous system and brings your stress down. So for treatment, so hugely self-care, alternative therapies. This is showing acupuncture here, and then cognitive behavioral therapy and non-hormone medicines as well. We'll touch on antidepressants, and then hormone replacement therapy are big ticket items for the general treatments for menopause symptoms. To start with, talking about hormone therapy for hot flashes that are not really getting any better if they're lasting a long time, hormone therapy can be helpful. This is a smaller amount of estrogen, and sometimes you can even do like a combined estrogen progesterone. So you usually want to start this before the age of 60 for symptoms. You could still start it after the age of 60 if you're still having symptoms at that time. It's really not recommended if you have a history of breast cancer. From your breast cancer doctor, if you've had breast cancer, talking to them or asking them. So a lot of the reason behind this is because a lot of breast cancer binds estrogen. So if you have a history of breast cancer, you're at increased risk of getting breast cancer if you start estrogen therapy. But there's some forms of breast cancer that don't bind estrogen. So just seeing with your doctor, most of them do bind estrogen, but if you are one of the cases that don't, you may still be able to do hormone therapy if you're having really bad hot flashes. And then if you do have a history of heart disease, like mild hypertension is okay, but if you have had surgeries or you have significant hypertension that's not controlled with medication, then you shouldn't really be doing hormone therapy. If you have had a stroke before, if you've had blood clots, if you have liver disease. So this is big because a lot of people don't really qualify for hormone therapy because of that risk. So that's why doing some other things for your hot flashes may be helpful. But then also, depending on what your risks are for stroke and heart disease and blood clots, you may be able to qualify for very minimal, very low dose of estrogen that may help with the hot flashes. So asking your doctor about whether you qualify, but if you have had a stroke, if you have had a heart attack before, you will not qualify for hormone therapy. Another thing to talk about, like maybe a family history of stroke and heart disease, or if your parents or brothers or sisters have had a stroke or a heart attack under the age of 50, then I would recommend not doing hormone therapy because you may be at increased risk. If it happened at an older age, it's probably not as big of a risk. And then having blood clots. So DVT is deep vein thrombosis. So that's the clot in your leg that they often warn you about when you go on planes and stuff. So trying to avoid estrogen therapy for that. If you have a mild hypertension, you may still qualify. Some of these other forms of estrogen therapy are much more smaller doses and really minimal doses, especially when it's absorbed through your skin. So you may still be able to do those if you can't do the pill or you don't qualify for the pill because of hypertension or heart disease or stroke. Some is combined estrogen progesterone. So similar to how birth control pills are, because they have the same sort of hormones, but for hot flashes, for menopause, it's much lower doses. Some people even feel like they benefit from doing birth control pills that are very low dose, but you really don't want to do the regular birth control pills because that's too high of a dose. Having too much estrogen and progesterone can cause your periods to start again or like do other disruption in your body. So really only the very low dose birth control pills can help. These are available in pills that you take, also skin patches, vaginal rings, skin gel, skin cream, or spray. There's different ways to get that hormone therapy. And then vaginal estrogen is another big thing if you're having vaginal dryness, if you're having pain during sex. It likely is from menopause. If that's starting and is newer, it's likely from vaginal dryness. So a big thing is making sure to use lubricant during sex, but then also there's vaginal estrogen. There's also a vaginal lubricant cream like to use outside of sex as well, during sex too. They're just non-estrogen lubricant creams that you can use. And the vaginal estrogen, I suggest doing some of those creams initially, and you could get those over the counter. I know Replens is one that people have used, and the generic names or versions of those are also available over the counter. So you can use those. And then if you're still having dryness or it just only lasts like a little bit of time, then that mucosa of your vaginal lining really may need some hormone help. So it may really be from that estrogen because that lack of estrogen really can dry out your mucosa. Then using vaginal estrogen cream, a vaginal insert, or there's like a flexible little plastic ring that you can put. I recommend doing the creams. I think people have that the most, or the vaginal inserts, but you can decide what feels best. And then a big thing in terms of medications for menopause that we touched on are antidepressants for mood issues. So a lot of people really benefit from that. There's so much alternative therapy that we can do to address our mood. Sometimes it can feel very debilitating. So really therapy and and antidepressants are hugely impactful. And they say that doing antidepressants and therapy together are the most beneficial at actually addressing mood problems at any level around menopause or outside of menopause. And antidepressants, they're not all the same. Even when they're in the same class of antidepressants, there's some that may work better for you. Often with people that have really bad mood symptoms, there's a lot of mixed feelings about antidepressants overall because there are several of them. I don't love throwing medication at things, and a lot of people don't want to take medications for mood, but because this is really something physical happening in your body, sometimes you do need that extra help, and it can be so hugely impactful. Your mood affects your entire life. I've seen a lot of people start antidepressants, even have to play around with which one is best for them. So you always start on a low dose, and your doctor, based on whether it's like more depression or anxiety, they may select one that's more right for you. But there's always a good handful of antidepressants, like 5 different types at least for each person to try. Not saying you have to try 5, but at least giving like 2 or 3 a chance if that's right for you. And then for estrogen and osteoporosis, I wanted to touch on. As your body decreases estrogen, it actually plays a huge part of building cells that actually build up your bones and maintain your bones. I know bones seem like this stagnant thing that isn't really changing. There are a lot of cells within our bones that are doing a lot of work all the time to keep our bones strong and keep the balance in our bones. So estrogen is a huge part of influencing those cells that are doing that. That's why as estrogen decreases, there's less of that. So there's less of the cells that are building up that bone density. So this can cause your bones to be a little weaker on the inside. This is different than osteoarthritis or rheumatoid arthritis that are affecting the joints. The joints are the spaces between bones that are connecting bones to other bones. And this is really your bone density. So this is the thickness, kind of what you see here, kind of that density, that thickness and sturdiness of the bone. So really important during menopause and after to protect your bones. So taking calcium and vitamin D supplements. Vitamin D supplements we should all be taking in New York. And I think there's always been variable things from the medical side of whether people should be taking vitamin D supplements. You do want to be careful on how much you're taking. So really, I think getting your vitamin D levels checked. There's different levels to how low your vitamin D is and how much you should be taking. But in general, even if you have normal vitamin D, the amount of vitamin D that everybody should be taking when you're younger than 70 years old is at least 600 international units is like how vitamin D is measured. If you're over 70 years old, because of this increased risk for osteoporosis, it's like 800 international units. So a little bit more. This is not saying that you should have a supplement of this, but that's the amount your body should be getting. You do get some from the diet and from sun, but I think if you're over 70, like even taking like a 600 unit at least, or even more. And then your goal calcium is 1,000 to 1,200 milligrams daily. And we'll talk about some calcium sources in a second. Staying active, especially now that there is more sun out, trying to get more vitamin D from the sun is hugely important. And we'll talk about vitamin D again too, but it's something that's actually sometimes hard to get from the diet. You do get some, but it can be hard to get from the diet. So doing some sort of supplementation for that, I would really recommend, especially if you're over 70 years old. And that's another note just about osteoporosis, that this takes years after menopause to actually start affecting your bones in a significant way that puts you at risk for fractures or breaking your bones. So that's why, especially after like 65 or 70 years old, as you get older and you are living a longer time without estrogen, that's when you really see that impact on your bones. Staying active is huge at protecting your bones because, like we said, bones aren't the stagnant thing. It's really affected by movement, by chemistry, by the cells that are working within them. Really having some movement of your bones is really important, but moving them properly that you're not hurting your joints in a bad way, but still staying active is really important. And then for bone density tests, everyone over the age of 65 should get a bone density test. This is to evaluate for osteoporosis. And especially if you've had a fracture before then, you should get evaluated even before 65. But after menopause and before age of 65, if you have family history of osteoporosis, if you smoke or if you drink alcohol frequently, those put you at risk factors. Also, if you are lower weight, that puts you at risk factor for osteoporosis. So you can even get a bone scan younger than 65 if you've had a fracture. Those are all reasons you can get a bone scan under 65. Those are reimbursed by Medicaid, like even if you have risk factors or even if you're under 65 and have risk factors. So menopause itself and just having less estrogen puts you at risk for osteoporosis. And that's why every woman over the age of 65 should get evaluated for osteoporosis. And then also younger than 65, there's alcohol, smoking. If you're lower weight, if you have calcium or vitamin D deficiency, which a lot of us do have vitamin D deficiency. And then if there's other medical conditions, calcium absorption that your doctors talk to you about, some like parathyroid tumors, and then corticosteroids and certain medications, anti-seizure medications often decrease your calcium absorption. And then for men, having lower testosterone or having a smoking history may put you at risk. And then generally getting older and having family history and having an inactive lifestyle can all be big risks. For calcium foods and things you want to make sure you're having frequently, leafy greens are really good sources of calcium. Bok choy, collard greens, kale, spinach has a decent amount of calcium as well, broccoli, and then edamame. Tofu has a lot of calcium. Rice typically does too. And then breakfast cereals usually fortified with calcium. Almonds are a really great source of calcium as well. And then almond milk, soy milk are also good sources, as well as sesame seed and orange juice. And then vitamin D, a lot of animal-based foods have vitamin D. It's actually harder to find in a lot of foods in general. We want to be avoiding pork because of a lot of the other fattiness that's in pork. And then butter, of having too much saturated fat. Some fortified dairy may be a helpful source of vitamin D, and eggs, as well as mushrooms. And mushrooms are a really great source, sometimes can be a little bit more expensive. So the biggest thing for vitamin D is trying to get it from the sun and then also from supplements. Also resting and prioritizing your sleep, eating good protein and healthy fats and veggies and fruit, and then the calcium and vitamin D. And then omega-3 that's often found in fish and as well as a lot of veggies as well. It's a fatty acid. It's a good food quality to have and to be taking that can affect your bones well. Happy Mother's Day to everyone and to people who have experienced motherhood in every different way.